So I just want to say it's very, very happy for me to see so many people here today for our Norway Day. So I'm just gonna invite now our division, head of division in the information management and methods, Bente Sundlo, to come up and give a warm welcome to you guys.
Good morning, everyone. So nice to see many of you here, and I believe I did meet some of you last night. I hope that you had a good time at the Munch Museum for those of you who attended there. And to be honest, the Munch Museum is one of my favorite museums in Oslo. And I for sure had a really good time. Welcome to Oslo, and thanks for coming to this April business meeting conference outside of England, the first outside of England. I'm Bente Andersen Sundlo, Director General of Division of the Information and Management and Methodology at the Norwegian Directorate of Health. We are very proud to be hosting the SNOMED CT business meeting and to get the opportunity to have our own conference day with so many international guests. The management of health data has become more and more important over the years, and we find new ways of using data and sharing data. Standardization of clinical care and the clinical communication improves collaboration and contributes to better patient care. We truly believe that standardization in the clinical information by using international terminologies and code systems. It reduces the documentation burden for clinicians and ease the use and reuse of clinical information in the electronic health record. This also benefits the patients in reducing unwanted variations in treatments and minimizing the risk of misunderstandings between health professionals. The Norwegian Directorate of Health has the responsibility to develop and maintain national normative products that supports the goals set for healthcare services and public health. We create and maintain the National Antibiotics Guideline, as an example, and the guideline gives health professionals clear advice on when to treat without antibiotics, when antibiotics are needed, and which ones to use. The goal is to help reduce the global threat of antibiotic-resistant bacteria. This guideline is based on another product that we manage, the SNOMED CT and its Norwegian extension. So this is a very good example on clinical use in Norway. And it's also a very good example on how we take our own medicine, so to speak. We use our own guidelines to maintain other guidelines. We look forward to exploring new opportunities connected to standardization, terminology, and code systems, and cooperate internationally in further digitizing Norwegian healthcare for use and reuse nationally and internationally. Thank you for this participation this week and today. And I really hope that you'll have an inspiring day and that you make new connections and friendships across clinical fields and national borders. Please enjoy the rest of today's program.
Thank you very much, Bente. It's so nice to have somebody who's cheering us on. So thank you very much, Bente. So, and then now I will invite Don Sweete, to also the CIO of SNOMED International, to say a couple of words before we start the rest of the program.
Thank you, Alfhild. Good morning, everyone. Come on. Did you have a good time last night at the cultural event? Oh, come on. I want to thank the Norwegian NRC, Alfhild, certainly her boss, certainly all of the people that work so hard in the NRC. It's been great to be part of this conference this week. We certainly have accomplished a lot. From a SNOMED CT perspective, it's been a wonderful conference with lots of information shared, lots of new ways of doing things. So that's extremely gratifying, certainly for our team, and certainly appreciate all the support and help from Norway in that. I want to thank Alfhild, who for all of the days we're here, we had nice, sunny, warm weather, and hopefully people got out to see the sites in Norway and hopefully spent some money to promote economic growth. From a SNOMED CT perspective and from a SNOMED International perspective, our goal is really to get to the point where we as human beings can travel around the world and our information follows us. And the way that that's done is because the information is coded and it can be stored and transmitted safely and securely, so that if you're ever in need in another country, there's a summary record there that can show whoever is treating you for something that may be happening with your health. They can access that quickly, understand it immediately, and provide the needed care in order for you to survive and move on with your time in another country. We've seen through the pandemic how key it is to have codified data to identify, based on symptoms, when people appear at doctor's offices, emergency rooms, or in hospitals, that those symptoms lead to a diagnosis that may indicate, as in the case of COVID, that there may be an outbreak, which allows the health system to react immediately, and in some cases proactively, to stop an outbreak happening. I hope that in my lifetime, this is the only pandemic that we've seen and we don't see anymore, but it's always better to be safe than sorry. I want to welcome you to this day. I hope you have a great day. I look forward to talking to you during the breaks, and certainly enjoy the show. Thank you so much.
Thank you very much. Thank you very much, Don. It's so nice to be able to be a part of this community and that we bring sharing each other on. I will just introduce myself. I'm Alfhild Stokke. So I'm I am actually a director in this new health directorate. So we are in the division that with the methods and with the information methodology. And that's one of the things that we are very passionate about. That is also to share on the things that we do with the SNOMED International. So I will just run you through the program, and also advise that this is also an online conference. So we will this will be filmed, so somebody will be able to watch it also later, but right now it's also online. So welcome also to the online people who's on here. So the program today will be I must say that we've really been looking forward to this day, because now we're able to show you a little bit about what we've been doing with SNOMED International in Norway, and how the things that's been going well, and probably some of the things that are obstacles also, so we can kind of, you know, share that together. And I think for everybody who's been a part of this, I can see a lot of friends here in the audience, so I was like very welcome to you all. So it's been a part of a long journey with the SNOMED International. So we started in the beginning of 2017. We became a member in Norway. So it's been a long journey. So now we can like kind of see to what's been the thing that we can take away from this thing. So the program today, it will be a keynote speaker who starts off the show will be Jørn Andre Jørgensen. Forward to hear what he wants to say. He's a dentist himself, but he's been part of SNOMED as long as we can kind of remember here in Norway. It's been really the one who's started with the terminology in Norway. So we're very looking forward to him to hear him and what he wants to say. After that, we will have a little break, so you can go and have some coffee. And then we will have very interesting thing about screening for intensive cancer and prostate cancer with an automatic data retrieval. So we're very looking forward to that. That's Kristin and Kristin, the two Kristins that we have to come and tell us about that. We will introduce them a little bit when we go ahead further here. So, and after that, we have Egil Gotaas and Marlene Martak, who's going to say something about SNOMED CT as an engine for our data-driven healthcare services. Very looking forward to that as well. And after that, we have one of the showcases that we're really also looking forward to hear something about, because patient care and that's been care plans been one of the really successful stories in Norway when it comes to SNOMED. So that's also very looking forward to that. With Gunnar Jorvik is going to say something about that. And then we have a little summary remarks from me, and then we have a lunch break. So we will have a nice lunch here in SAS Plaza. And after that, there is interoperability. Yeah, so the next part will be more the international part. So we have like first part was the Norwegian part, and then we have like the more international part, and then we have invited some of our very good friends, but also people who really, we try to find out who can like say something that would be very meaningful for us in Norway right now, in interoperability and about, you know, what's going on around this thing in Europe, especially because we're in Europe still. So that is the second part of the program, and we will kick that off with the interoperability journey from the Netherlands with Sylvia van Laar. So we're so much looking forward to Sylvia to tell us a little bit about what the Netherlands journey has been to be a part of SNOMED, but also interoperability. We're asking more than just SNOMED right here. We want to see how are they fitting in codes and classifications together. And the next session will be Lisinyu Kustramano, who will talk about the HTS initiative in Europe, and then also the use of SNOMED. That's very on the agenda right now. In Norway, we are talking about what we are going to do with the EHDS. So that's very important to us. Interesting to hear you saying about that. And then after that, we have Stephanie Wember, SNOMED. She will talk about SNOMED CT and ICD-11, and also a little bit more, I think, about the German journey with the SNOMED. So it's going to be very interesting to hear you also, Stephanie. And then we have the last keynote, I'll say, that will be Innovation Spotlight keynote, and AI and language models. So that's Anthony Check. That really looking forward to hear Anthony to talk about this and to say maybe some of the things ahead for us, what's going to be important for everybody when we are thinking interoperability, when we're thinking about how all these things are going to fit together, and how will the AI become a part of this. You know, so that's the program today. And then I think we will just can kick it off with Jørn Andre, if you're ready.
Well, thank you, Alfhild. Thank you, everyone. Thank you for having me. I'm very excited to be here. It's really cool to have SNOMED business meeting done in Oslo. As Alfhild said, I haven't been to SNOMED since the beginning of morning, but since the beginning of morning with dentistry. So as everything, you stumble into things. So I'll just briefly touch on that. That was in Stockholm. And a man called Mark Jerkowicz went around the table and said, "Could I please have your email?" And I thought, okay, you can have my email, that couldn't hurt. Well, congratulations, you are now the new dentistry clinical specialist group. And I've been ever since. And I'm very happy to have done that work alongside Mark. But I've not only worked with dentistry, I've also worked a lot with general medicine and with medication and things like that, especially during my time with Norwegian Directorate of e-Health, which is now a part of the Directorate of Health. And working especially with the common language and with Helseplattformen in their implementation and with medicines along Felleskatalogen and all the other great initiatives, also like the Cancer Registry, who started looking at SNOMED the way it should be looked at. And we can only hope it will move forward. And I'm hoping to give you some inspiration, which is not purely linked to dentistry, but I'm using dentistry as sort of the simple example. Saying that, I can't see why our methods couldn't be used across other parts of medicine. And I'll touch on that as well. So the punchline sort of today is that anything you can do with SNOMED CT, you can do with simple codes. You just have to manage and create all the relationships. And that's not an easy just. And that's the real strength looking into SNOMED, using it both for transferring information and especially analytics. So we have had coding lists for a long time, but it doesn't help with internal coding lists for unspecific registration and impossible exchange, especially across domains. So the strength of SNOMED, which I also could have had here, is the unique meaning of a concept across domains. But the real strength we're looking at when we're doing analytics now is in the relationships. So a few words about dental information. As opposed to, for instance, GPs, we have highly structured and granular information. It's simply because we do most of our data retrieval aligned to a tooth or the surface or region of a tooth. So we have a graphical interface. We click. Everyone is scared of the clicking. I don't know why they want to click a keyboard so many more times than a mouse. Somebody can explain that at some time. Because they're clicking the keyboard to great extent instead of actually choosing something from a standard, whatever. Anyhow, we're clicking teeth and we're clicking pre-coordinated defined diagnostics, findings, and procedures. We also have text boxes popping up if we like them, and we can add more text. So we have two kinds of information. We have graphical interface clicking, which is linked directly to a granular concept. Or we have graphical interface clicking, which then has a text that is a subtype of the at top. We have few concepts. I'm not sure if that's entirely true, because looking at general medicine, they don't have that many more. But in this world, few concepts, but many combinations. So this is a database we have been working on. It's not research, because we're not allowed to use that database for research because it's a clinical database. It is quality assurance inside a service. But we currently have a data set of 325,000 patients. The data is identical across Norway, so we could have 2 million. But since we're a separate county, GDPR, other regulation says we can't gather that data together easily. We're hopefully doing that in the future. We have about 32 million rows of information. And everything you see will be on that. You see a pie chart here, which says what kind of information do we have, 1% findings, about 30% procedures, a few observables, a little bit of planned procedures, some administrative. That's typically, I've sent you an appointment, or I've gathered some payment or something like that. And we have less than 1% unmappable. And they're not really unmappable. It's just all the strange things. We figured 99% was fairly sufficient. If you look at the granularity of the clinical concepts, that's up to 77% precise and granular information. Meaning the concept represents exactly the meaning the dentist had at a very detailed level. So this is where we really have our strength. It's another lecture. We did some of it in Atlanta. We use Snowstorm X and we post-coordinate everything, meaning we have about 30 post-coordinations we can use for cross-analytics. But I'm not going to dig into that. Just advocate that sometime let someone tell you about post-coordinations and doing description logic analysis based on the SNOMED model, because it really helps your analytics drive fast. So one use case which we have started looking at is automated risk assessment. Looking at this pie chart, what it shows is examined people who never have had a cavity since that year. So we examined about 36,000 patients only in our small county, because we're mandated to look at children every second year by the government. And we spent somewhere between half an hour and 45 minutes on each child, regardless of disease. So our idea was, okay, let's look, can we reduce that mandated examination to 15 minutes? Because we know they don't have a risk. We don't need to pull people in, put them in a chair, put the parent beside and say, you shouldn't eat that much chocolate, you shouldn't drink that much soda. If there really is no problem, they're not going to listen to us anyway. I mean, would you? I wouldn't listen to the doctor if I came in healthy and he said, well, you need to cut back on your fat, you need to cut back on this, you need to cut back on that, and then I'd go out running for a marathon. So we looked at this, and if we were able to isolate these people, you will see that out of about 40,000 examinations that week, we had responsibility for a lot more. 36,000 did not have cavities the next 4 years. Why were we continuing looking at and training those 36,000 individuals? So if we were able to limit that only to 15 minutes, just checking them, that would be an annual saving for Norway on 35 million Norwegian kroner, which, depending on current tariffs of trade and stock markets, should be about $3.5 million. That is, of course, one day it's 3 and the next day it's 4. You never know. That might not sound very much, but remember, Norway is a small country with 5 million people. It's about the size, I think, of East London. So I don't know how you would feel, Charles, if the NHS trust of East London could save $3.5 million with a simple risk assessment. It might not hurt. So how did we do this? This is a very poor treatment. No, poor drawing. I wouldn't do this normally, but it's illustrative. It's a sick tooth. It's a cavity. So we went from this structure you see over here, and it has an underlying table. I haven't disclosed the underlying table of the EHR because that's sort of IP for our EHR, and I wouldn't risk publishing that online. But we just made a simple equivalence table between their database structure and said, if this and this and this and that, then it means something. Well, it means that we have dental caries on the incisal ridge of the lower right canine tooth. Well, that I can write in SNOMED, a post-coordinated expression. And I can bounce that off Snowstorm X, and it will give me a code. So this is how we did it. We went from graphics to code. And we got, as I said, 32 million rows dating back to 2006, which are highly precise, highly granular, and can be sorted using simple description logic to see relationships. It also allows us to connect which tooth had a diagnosis, which had a treatment, which had a new one. I'm just going to show you some examples. We've done a lot. I could talk for half a day. And it's really cool. Of course, I think it's cool. I hope some of you are as great nerds as I am. We did also one more enhancement, and that's using text enhancement. So I'm not calling this NLP because it's way out. It's not NLP by a far stretch. But it's very simple because there are so few terms describing things. So if we hit a grouper like X-rays, we just looked for, well, are you saying intraoral? Are you saying orthopantogram? Are you saying cephalogram? Well, if you do that, let's define a more precise meaning. So inside the group, we were able to, as you see here, end up with only 36%, which were sort of a mid-grouper. We were able to say that, okay, 60% of this is actually a bite wing. It's when they put the film like this and you go, and they're looking for cavities. That's what we do by far most. So that way, we were able to even differentiate some of the groupers down to a more precise concept, leading us into those 77%. Now we were able to do simple longitudinal development studies. And these are just two disorders. It's erosions. They're skyrocketing. And this was sort of the gut feeling of all our healthcare personnel. But these graphs show it's actually true. We also had the gut feeling of people getting enamel misforming. We don't know why. We have no idea why this is skyrocketing. But it's for children born around, you can see around here. These are 18-year-olds. So somewhere around here, things starts happening. And this is 2000, kids born around 2000, millennium. It might be plastics, it might be something, we have no idea, but it is going up. So everyone say, well, this could be just registration practice. Maybe it's always been like this. Well, we know this function came into play in our EHR in 2010. So before that, we don't have valid data. But look at this erosion chart. Something's happening in 2013. These graphs are for different age groups. And here they're starting to separate. So if this was just registration practice, it should have been the same line for everyone, because why would I chart it better on an 18-year-old than a 15-year-old? So this is our strong indication. This isn't registration practice. This is a true increase in enamel misformation and erosions in our youngsters. And we started looking deeper into this, because now we could use these relationships I'm talking about. And I'm going to say first, lists are not the answer, because everyone's saying, well, I can just get a list and I can sort it out. Here are 32 teeth. But problem grouping 32 teeth. We have 52 because we also have deciduous teeth. Still not a problem. Imagine sorting 38,000 post-coordinated expressions by hand. You won't be able to do that. You have to use the relationships in SNOMED to sort your data. And this is where the beauty of SNOMED comes in. So I'm just showing you with a simple example, because if I showed you a list of 38,000 and showed you how they were sorted, you would probably fall asleep or something. But showing it with 32 teeth is possible, because now we could say, by these 32, you have a number. The number up here are how many of that kind of tooth had erosion. So now I can sort that into anterior and posterior teeth. So like I said, I could just pick that list. It's way harder if you go into all my data looking for all combinations of erosions and sorting those 38,000, which had to do with erosion, where, how. That I need a computer, I would do queries. But anyhow, most of the erosions were registered on the front teeth and almost 40% on the posterior teeth. Maybe not a surprise. Neither a surprise if we're looking at the anterior teeth, the ones in the front. Most of the erosions were into the mouth, on the lingual side, against the tongue. Looking at the lateral segments or the posterior teeth, it was on the occlusal surface. And this is things you can do. And if I had, or if I at some time get someone who could run AI search on this, they could probably tell me what's the most frequent combination. And we have started just picking up the surface here, and we're seeing a very unexpected finding. I have two unexpected findings. One is very simple. It's development of erosions. These are the boys, and these are the girls. Why are the boys experiencing more erosion than the girls? I don't get that. More surprising to us was these are the ones who only had erosions on their front teeth. These are on the posterior teeth. This is on both. No, none means it's on either on deciduous teeth or canines and things. That really doesn't matter. Why do you have either or, not both? Why you get these erosions? Are you getting the erosions because you have acid reflux or eating disorders or drinking too much energy drinks like Monster and Red Bull and things like that? Current theory, you get it in the molars if you're drinking too much acid drinks. You get it on your front teeth if you're having eating disorders or acid reflux. Maybe it's the other way around. I have no idea. What if we could link these data to other health records, looking for other kinds of problems? Could this be an early predictor of psychiatric disorders like eating disorders? Because we see these kids all the time. Could we capture something? So I'm going to leave it at that. But this is just one area. We are now gathering a lot of data which could be relevant if we could connect to others in a more appropriate way. Oh, it's jump, but it doesn't matter. Correlations, it's another thing we've been looking at. This is really not a very big surprise. It just states that if you have had a filling in your tooth, you have about 90% chance of getting another cavity. If you never had a filling, it's about 16. If you have a filling, it's about 25–26% chance of getting a toothache. If you never had a filling, it's about 2. There is also a difference between men and women. I didn't show you. So this is very simple. It's the correlation between having a filling and getting disorder. So now we're moving from current to future, and I'm just keeping, I get thumbs up for time, that's good. So everything you see now, we have done. Everything you see now, I would like to do. So I haven't been into, I'll just give you some examples. We've also done filling longevity. We can go down to the kind of filling, to the place in the mouth. We have a lot of data. We just haven't gotten it up running yet. We need a more, we need someone who wants to dig through our data all the time. That would give us really a lot of help. We also looked at production decline, production drop during COVID, not recovering. So we're doing a lot of these things, and I'll give you more examples. One of our most current is someone doing a master thesis using this risk assessment model. We can also go back and then we can validate that because we have 17 years of data. So, but okay, moving into the future. This is also an old graph just done for fun. I wish someone would do it not for fun. So there aren't many patients. As you can see, there are only a few patients because it's a limited data set. We trended 3 things. We trended the green line is myocardial infarction, the brightly green line is influenza, and the blue one is nausea. See the drop in influenza? Do you think it's an actual drop? Or is it because this is Christmas Day and you wouldn't see the doctor? Possibly. So most of us, if we get sick, we have to go to the doctor the day before Christmas. Christmas Eve, we're busy. Christmas Day, we're lying there. Boxing Day, still busy. Oh, the doctor is opening up again. Let's go get a test. But look here. Here is a major increase in myocardial infarction. So let's single out the men. Flat, 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 boom. Here's the weather. What's happening here? We have a heavy snowfall with about 0 degrees. So the old men are shuffling snow because they have to be the proper men of the family. They really shouldn't do it because they're not working out the other 364 days a year. So they go down with a myocardial infarction. So this is like sort of, we all have the suspicion. What I would like here is to see, does it affect the kind of myocardial infarction? Is there an effect of outcomes? Is there an effect of what kind of medication they were in? So that's why I've put up, oh, clicker has stopped. This is a very bad moment for them. We're back. So use cases. These are just throwing out ideas because now I'm in a room where I know a lot of people working with healthcare research are. And now, of course, I come from the dental perspective, but could we please get the correlation between oral disease or dental treatment and acute heart conditions? We all think it's there. We almost know it's there, meaning if you pull a tooth, you could end up in the hospital 4 weeks later. They will never know it's because you pulled a tooth, because it's 4 weeks ago. But having that correlation, having also the correlation stating, is there a kind of myocardial infarction that is more frequent amongst those than amongst others? And more importantly, is there any kind of medication we can use for risk patients to avoid that kind of complication? Because now dentistry won't save you $3.5 million. It'll save you a lot more if you can avoid people going to the hospital or even returning to the hospital. So what subdiagnoses of heart conditions are most frequently related to oral disease or dental treatment? Which oral diseases or dental treatment have the most significant correlation? That's the other way around. So when do I have to give preoperative antibiotics to prevent my patient from going to the ER 3 weeks later? And did medication influence incidence or outcomes? Which medications? So I'll go out there and say, I think SNOMED CT makes cross-domain analysis easier. Everyone who says, well, we can have a domain-specific terminology. No, you can't. You can have a domain-specific ref set. But you need to have a common terminology across healthcare to be able to do these kind of cross-domain analysis. And SNOMED CT will help you find the questions you never thought of asking. Like the question, why are someone getting erosions on their anterior teeth and not their posterior and the other way around? Why doesn't the acid just go into the mouth and affect all teeth? And I'm sure medicine will also encounter a lot of surprising findings and surprising questions moving ahead. This is another example of cross-domain, and it's my lab. I'm just going to use, I think I have 2 to 3 minutes. So this is, when I say the future, this shouldn't be the future. This should be current situation in a country like Norway. We have a highly integrated healthcare system. They're all government. They should be working together. It's small, it's neat, not a lot of people. And we have a culture for allowing people to share our information. See this picture? This is an elderly woman being examined in her bed. This is the everyday for a lot of my employees. Not my employees, my colleagues, sorry. So this is actually one of my colleagues examining someone lying in a nursery. No, it's not a nursery, I'm sorry, bad English. Yeah, nursing home, thank you. So if you're in that position, we have a green, which has where the size has made it invisible, but it really doesn't matter. It's a national concept because it's administrative. It doesn't belong in the international edition, but it's very useful for our care plans in the national edition, not the international. So it's just saying she has had the information that she is now in a nursing home entitled to free dental care by the public sector. Well, she has a toothache. When that goes, I might get to know anything else than that, but that's okay. I at least know the patient has a problem and she has expressed the problem. That's a situation we experience quite a lot. She could come to the dental clinic or the dental clinic could come to her. Now we should be able to send a reply through the messaging service or data sharing in Norway saying she needs special care of dentures. That should go into her nursing plan, which I hope you will hear about sometime. I think it's later on today. Gunnar will talk about that. This should be individual plan. And for those of you who haven't been here, some of you will get there eventually. we actually get people having like dinner from 3 days ago lying in their mouth because no one has cleaned. We even have prostheses that are stuck because they have grown more or less into the gum. We need to tell them to take out this prosthesis and clean it. It's as simple as that. And we know it affects dementia, we know it affects lung disease, and we know it affects nurturing. Why do we need to make phone calls to make this happen? I can send an email, I can use an online service for almost everything, but not for passing relevant health information. The other one is, we actually have a lot of cases where the hospitals have to send people back because they have no idea of dental status and they need to have that idea before they can start a cancer treatment. So we have canceled cancer treatments. When the patient arrives, they're sent back home because they have no knowledge of it. But back to the denture. I think most medical personnel will agree it's very hard to intubate a person with a denture. You need to remove it. Then you need to know it's there. If you don't need to know it's there, if you don't know it's there, you will have a problem when you're doing the intubation. So I'm going to stop now. And I'm just going to say, we have two areas of cross-domain needs and use cases using a common terminology. So this isn't just dentistry. This is talking together, doing analytics for the better of the patient and exchanging information for the better of the patient, where I think precise clinical terminologies like SNOMED could be the key to actually achieving this future view, which should be there tomorrow, not in a few years. Thank you very much. Questions? Is that? Thank you.
I need to speak here so people can hear me. So yes, so thank you very much, Jørn Andre. This is very interesting, of course. I love what you're saying because things are really moving forwards on the dentistry area. So now I'll just want to open up for a little bit questions. Is there anybody who wants to ask Jørn Andre about something? Just think about that for a little while, and then maybe I'll just kick it off. Because one of the things that we've been working together for a couple of years before, and then one of the things that the Doctor Association was always asking us, can we actually see some use of doing this, getting into SNOMED International? Is it clinical use? Can we actually see something prove? Do you think that we're about to prove something there on the dentistry area?
Yes, we are proving it. We are actually now looking at, as I said, first risk assessment because it's so visible to our politicians. So if we can save, like I said, about in Vestfold County alone, it'll be about $4 or $5 million. No, 4 or 5 million kroner, 400,000. That's about 5% of our total budget. So if I can save 5% of the budget, I think they're interested. But then we're not looking into the big bucks. The big bucks are in dentistry. What is more costly in dentistry? Everything that's an empty chair. It's not. It's when the chair is occupied by someone you have to do things over on without claiming pay from them. So if a filling falls out and I have to do it over again, that's sort of the most expensive situation. So I'm asking myself, could SNOMED be used in a hospital environment to reduce readmission? How much would that save the Norwegian healthcare system if you were able to reduce hospital admission by, say, 10%? And we have looked at it, so we know that some kind of fillings, if we do it this way, have a lot less chance of survival than others. So I think we're already there.
That's very good. Great news, and thank you. So we have a question, Mona?
Yes, Mona Stedenfeldt from Helseplattformen. Thank you for a great presentation. I think you're actually tapping into what we have talked about, Alfhild, the gold mine of data, health data as a gold mine to find new information that can come back to the healthcare giver and the patient, bridging healthcare professionals. And at this point, we are in Norway starting to actually get pools of these SNOMED that can be interconnected. Now, my question is, we need to get the researchers on board. I feel like this is not the research environment is not aware of that this gold mine is now starting to really grow in Norway. And how are we going to be able to get their attention? Because once we get their attention and they start digging into this, then the job of getting SNOMED into all systems will become easier. And also the healthcare givers and the clinicians will be more willing to actually use the structural journal system. So the question is, how are we able to really publicize this goldmine of data?
I have no idea. Because I went actually with my data to a research institution and said, well, here you are. And they said, well, no, thanks. We're kind of busy. We're about to make a analysis of a snapshot of 500 patients, and that's what we're planning. And I said, well, you wouldn't care for having like 300,000 instead? No. Because they needed validation, blah, 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 blah. But these data are, if you look at them, one, they're real life. So I think the way, the approach we have used trying to go forward is demonstrating the kind of data we're able to produce and hoping that they'll someday catch on to say, well, maybe I don't need to make this small study with 100 people. I could use this large study with 100,000 people. Charles.
Jørgen, thank you so much for a really interesting presentation, and thank you for your reference to East London. Always appreciated to know that we exist in your mind. I have two questions, I think. One does refer to the East London question, which is, as you probably know, there's an extraordinary diversity of population in East London with, maybe 100 different groups of people from different countries and so on. I'm assuming that in your data set, you have not only sort of age and gender and so on, but you have the data on those kind of questions. And is there a hint that the incidence of dental decay is different in different ethnic groups, or is that not yet explored? My other question, which is really, I suppose, my lack of knowledge and experience, but I really only know about what happens in our dental hospital. So that's really, referrals for progressive disease from general dental practitioners in the environment. Our staff are beginning to register and define SNOMED in our electronic health record. And I have one or two stars who are going, I begin to get this. I can do what Jørgen could do, or will be able to sometime in the future. But I have no sense that ordinary general dental practitioners in East London have even heard the word SNOMED. I think they use electronic records, but can you give us a sense of what you've done in Norway to make the ordinary guy with a chair out there use the systems that you described?
First question first. We know a lot about the incidence of caries as a disease throughout socioeconomic patterns and geographicals. We are able to link our data through the Norwegian equivalent of a social security number, which is unique, and we are able to connect that to other kind of data so that we can look deeper into that kind. I would very much like for someone in our research community to look at erosions the same way and see if that follows the same pattern. I don't think it does. Second question, we didn't make the dentists aware of it. We connected to the EHR as is. And I think I've said this before in Norway, at least, that the first person who shows healthcare personnel's SNOMED code should be just led out of the room and taken away. Because SNOMED isn't about codes, it's about terms, it's about understandings. So we simply link the codes to the current understanding and the current registration practice in the dental surgery. Doing nothing with the EHR except connecting to its database structure. And since the structure was already so hard set, we were able to retrieve this kind of data. And we are also able to, and we're going to do it, to verify how many are actually putting in data. But our current impression is that they are really good at it. And we will get a lot of, most of them even chart the complete series of how the teeth are looking when they come in for the first time.
Yes. Any other questions? Somebody wants to say to Jørn Andre? Okay, so I'm just going to say thank you very much from the Director of Health, Jørn Andre, for what you've been presenting to us today. And then, yeah, we had a little gift there I was giving to, and so thank you for that. And then I'll just say that we'll finish up this session, and then we'll come back in half an hour. Though it will be 10:30 because some people are online. So 10:30, please be sitting at your seats again. So thank you very much, Jørn Andre.
Thank you.